and briefly introduce Dr. Virmani, who doesn't require any introduction, but that is the customary. And thereafter, he can give his views about the topic. I will request Dr. Arkemisha to take over. Dr.
Thank you, Dr.
Ashok
Satish.
is
Thank
not
you,
present.
Dr. Satish,
Yes, sir.
for asking me to chair the session of a very good friend of mine, Dr. Anil Vermani,
Great, sir.
on heart failure.
Yeah.
And you know,
Thank you,
this,
Dr. Akimcha, for your kind introduction. Am I audible?
yeah,
Yes.
My slides visible?
yes.
Yes.
Okay, thank you. Thank you, Dr. R.K. Mishra, for a wonderful introduction. Now I will start my topic. First of all, my tribute to the legends in cardiology from Jharkhand who are not with us. My salute to all the stalwarts in cardiology, whether it be interventional or preventive, who have taken Jharkhand to very high standards in the last few years. Now, what I will talk about today is heart failure with preserved ejection fraction. Often
Your voice is a bit, broken. So can you bring your mic towards your mouth?
okay. Can you hear me now?
Yeah, better.
So the topic is heart failure with preserved ejection fraction, often forgotten clinical enigma. Now, we remember when Cornwall defined heart failure as the inability to provide adequate cardiac output to the body at rest or with exertion, or to do so only in the setting of elevated cardiac filling pressure. Clinically, it is a clinical syndrome characterized by breathlessness, fatigue, and edema caused by an abnormality of the heart. Now, these are basic facts that we remember from our cardiology classes. When you look at the evolution of ejection fraction in heart failure, most of the studies have been done in patients with reduced ejection fraction, and some in ejection fraction between 40 to 50%, which is considered to be a mid-range ejection fraction. There are hardly any studies in what is normal ejection fraction or preserved ejection fraction. Now, it was in 1980s that we recognized heart failure with a normal systolic function, and this was associated with hypertension. So the dictum was to treat risk factors like hypertension, diabetes, obesity, etc. And a unifying theme for both heart failure with reduced and preserved ejection fraction is congestion. So the standard treatment for symptom relief is the use of diuretics. It was in early 2000s that we started focusing on what is known as diastolic dysfunction. And this was nothing when compared to controls, there was impaired active relaxation and increased passive stiffness of the left ventricle. Now, this was related to complex and heterogeneous changes, but not limited to cardiomyocyte hypertrophy and fibrosis. In the late 2000s, we realized that this diastolic dysfunction may be accompanied by what is known as associated systolic dysfunction. And this systolic dysfunction was assessed by global and circumferential strain reduced at rest and exercise. Of course, diastolic relaxation velocity was also reduced. In 2010s, we started making criteria, understood the heterogeneity, and understood something about the so-called mid-range ejection fraction. In the 2016 European Society of Cardiology guidelines, we know that we knew about heart failure with reduced ejection fraction, and we knew something about so-called preserved ejection fraction. But what came into importance was heart failure with mid ejection fraction. Now that was ejection fraction between 40 to 49% compared to the LVF of less than 40% in heart failure with reduced ejection fraction and more than 50% in heart failure with preserved ejection fraction. Now this also had elevated levels of natriuretic peptides, and they had relevant structural heart disease, LVH or left atrial enlargement, and diastolic dysfunction. So it appeared that mid-range and preserved were almost similar, but that was not to be there, because when we look at the the whole scenario of mid-range, look at the age, look at the percentage of women, look at the presence of coronary artery disease syndrome, age, present atrial fibrillation, CKD, anti-Bruneke, except for CV risk, everything appeared to be more like reduced rather than preserved normal. The preserved or normal had a higher age group where the women were predominantly more, the coronary syndromes were less, atrial fibrillation was much more. CKD was very, very prevalent in patients with preserved, and there was CV risk and anti-BNP were not very commonly raised. So when we look more closely at this so-called 40 to 49%, there is no evidence-based therapy. And these patients, at that time they said between 35 to 50, it was known as a gray area and probably had primarily mild systolic dysfunction. And it was then realized by the 2016 ESC guidelines that we must try to understand this heart failure with mid-range ejection fraction before we go to preserved ejection fraction. Now, earlier trials in the heart failure with preserved ejection fraction were the CHARM preserved, I preserved, TopCat, and the PEPS VHF. And all these, sorry, it's not moving. So these trial designs, heart failure, where the ejection fraction is more than 40%, all these trials failed. So we started asking, does heart failure with preserved ejection fraction exist? Now, if you look at the post hoc analysis of these trials, except for the charm, uh, all of the trials did not show any difference in the heart failure hospitalization. And when we look at the charm, we see that this was basically in the not only in the reduced ejection fraction, but also in the mid range. But nothing was, there was no benefit seen in those with preserved ejection fraction. So RAS inhibitors may be beneficial in the mid range, but they are not beneficial in the preserved ejection fraction. What about beta blockers? Now, beta blockers again have shown a reduction in all-cause mortality and cardiovascular mortality, both in the reduced ejection fraction and the mid-range, but they did not show any benefit in the reserved ejection fraction, that is less than 40%. TopCat study showed that the mineral receptor antagonists like the spironolactone again had a greater effect with lower ejection fraction. So they also did not have any significant effect in heart failure with preserved ejection fraction. So when we compare the mid-range and the reduced ejection fraction, they are almost similar because they have effects, the treatment effects of ARBs, MR and beta blockers in sinus rhythm are both relative and absolute. They are well seen. But in patients with preserved, we do not see any effects of these three drugs. Now, we know heart failure with ejection fraction is because of acute coronary thrombosis of myopathy and neuroendocrine activation leading to direct myocardial injury, cell necrosis and apoptosis, and ultimately it is secondary organ remodeling. But when we look at heart failure with preserved ejection fraction, not mid-range, but preserved ejection fraction, we find that there are comorbidities which are very important. And these lead to reactive oxygen species, microvascular inflammation, endothelial activation, and ultimately microvascular ischemia and concentric alveoli. Basically, comorbidities and multi-organ remodeling that leads to secondary heart failure with preserved ejection fraction. Now, when we look at the so-called preserved ejection fraction, in 2005, it constituted 33%. In 2010, it constituted 39%. So there appeared to be an increasing trend. And this increasing trend of heart failure with preserved ejection fraction was seen more in black women and black men as compared to the whites. And we initially, and then we saw that almost 50% of the population coming with heart failure had preserved ejection fraction. And it was said at that time that by 2020, 65% of the patients hospitalized with heart failure will have an ejection of more than 40%. That is including the mid-range. Now, unfortunately, it occurs more in an aging population. If you see between the age of 60 to 80 years, heart failure with pre-ejection fraction is dominant. And the dilemma of heart failure with ejection fraction is basically we want to know whether is it a real heart failure? Is it part of a spectrum or a separate entity? Or is it just a collection of comorbidities or pathophysiologically distinct? Now let's look at this. When we look at the classical heart failure domains, like decrease in exercise capacity, neuroendocrine activation, and decrease in the quality of life, they are similar to heart failure with reduced ejection fraction. So that means it is a distinct, there is no doubt about it. And when you look at the comorbidities, we see that the patients in these trials, like the eye preserve, charm preserve, and DIG PEP, where the heart failure with preserved ejection fraction had a similar increase in heart failure hospitalization as was seen with patients with only hypertension. Unfortunately, we also now we want to see whether it is a part of a spectrum or a separate entity. Now, it is both. As a part of a spectrum, heart failure with preserved ejection fraction is a transitory stage to heart failure with reduced ejection fraction.
मानी परसों स्टीयरिंग व्हील पकड़ेगी, हाय हाय।
Can you mute? Can you mute?
गाड़ी
Please?
आगे बढ़ेगा तो
Can you mute, please? It has got a unimodal
लेडीज को मत
distribution.
मार देना,
Mr. Panda,
घास
please mute
घास को ऊपर
yourself.
ले जाने के लेडीज को मत मार।
No, some disturbance is coming.
Yeah,
Captain,
Mr. Suman Panda, please mute yourself.
सॉरी
you can have your romantic talks later. Eccentric LV remodeling in some hypertensive heart diseases and subtle LV dysfunction, and along with severe systolic function. But as a distinct entity from heart failure with reduced ejection fraction, we see a bimodal distribution. And this is a distinct pattern of LV remodeling. And this distinct cellular, subcellular, and interstitial characteristics with a distinct response to trials. So heart failure with preserved ejection fraction is more than a collection of abnormalities. It is indeed a separate entity. But unfortunately, comorbidity increases with increasing left ventricular ejection fraction in heart failure and diminishes our ability to modify disease. Now, if you look at the epidemiology, as I said, this is, I'm sorry for the table, but majority of the patients are elderly women with hypertension. And this was a wonderful study where a prospective observational study in more than 11 regions and 44 sites, where 7,000 patients were studied in stage C heart failure. And we saw 5 clusters. One was a young, these people had few comorbidities. They had reduced ejection fraction, eccentric hypertrophy, and best outcomes. The other was ischemic, and these were male patients with coronary artery disease, ischemic etiology. They again had reduced ejection fraction, eccentric hypertrophy, and second burst outcomes. The third group was the elderly or those with atrial fibrillation, and they had a history of stroke, and these were preserved ejection fraction and concentric remodeling was seen. The fourth group was metabolic, and these people had high prevalence of obesity, hypertension, and diabetes. And again, they were preserved ejection fraction with concentric remodeling. And the last group was lean diabetic. Again, these patients had a low BMI, they were preserved ejection fraction, concentric hypertrophy, and had the worst outcome and quality of life. So it is these three that are the predominant heart failure with preserved ejection fraction. Elderly or with atrial fibrillation, usually seen in the Western European Union, metabolic, usually seen in the United States, and lean diabetic, this is uniquely Asian with worst quality of life and worse outcome. Now, we also see patients who are young, and compared with controls, these young patients have a threefold higher death rate and twice the prevalence of hypertrophy. Now, how to diagnose? We must recognize the complexity of the diagnosis due to non-specific symptoms. And the one should diagnose based on symptoms typical of heart failure, signs typical of heart failure, normal or only mildly reduced left ventricular function. And according to the ESC guidelines, we must have objective evidence of other cardiac functional and structural alterations and elevated levels of NT-proBNP to more than 125 pg per ml in sinus rhythm. The ACC, AHA, and Heart Failure Society guidelines also specify for evidence of abnormal LV diastolic dysfunction determined by Doppler echo or cardiac cath. And this is a diagnosis which is very challenging. There's a diagnostic score, and to make it simplify, let me tell you the gold standard of the diagnosis is a pulmonary capillary wedge pressure of more than 15 millimeters at rest and more than 25 millimeters during exercise. And this is the score I was talking about, S2F score, which is heavy hypertensive, a BMI more than 30, using more than 2 hypertensive medicines, paroxysmal or persistent atrial fibrillation, pulmonary hypertension diagnosed on Doppler echo, elderly more than 60 years, filling pressures with Doppler echo showing E by E positive 9, more than 9. But atrial fibrillation is one of the very important subsets, and that is often associated with heart failure with preserved ejection fraction. This is another score. I just want to mention here that when you are looking at biomarkers, you must know whether the patient is in sinus rhythm or is having atrial fibrillation. In sinus rhythm, NT-proBNP more than 220, whereas in patients with atrial fibrillation, NT-proBNP has to be more than 660 for diagnosis. Now, as far as the diagnostic performance of these scores is concerned, in the Asians, it has a reasonable specificity of 81 to 98%, but has a low sensitivity of 48 to 76%. So what contributes to the diagnosis of dilemma? It has to be considered within the context of the natural history of the disease. There is a limited understanding with respect to factors driving the progression of the disease. And we must consider differences between hospitalized patients with exercise intolerance and hospitalized patients with rest congestion when considering the relevant diagnostic tools. So what dominant form of heart failure in aging populations represents real heart failure with treatment response distinct from heart failure with reduced ejection fraction, high burden of hospitalization for heart failure and death. And it is not only about elderly hypertensive women, but also young obese men and lean diabetic Asians. The diagnosis starts with the clinical signs and symptoms, then the probability criteria, comorbidities, and in and outpatient. What about the treatment of heart failure with preserved ejection fraction? Now, if you look at this Paragon heart failure trial, this was done in patients with ejection fraction of 55% or more with the use of harnese, and valsartan. Now, what did this show? This showed there was lower level of N-terminal B type nitrogen peptide, a larger reduction in the left atrial size, and greater improvement in the NY-HA functional class than valsartan alone. The primary composite outcome, however, was not reached, but not achieved. But what was seen that these patients were phenotypically heterogeneous, and there was a suggestion of benefit in patients with mid-range ejection fraction of 45 to 57% and in women. And this is across the function. The ARNIs work much better in patients with lower ejection fraction, but they also work in patients with mid-range ejection fraction and better in women. Now, we must not forget that there are certain treatable or etiologies which should be found out, and one of them is amyloidosis. Wild type transthyretin amyloidosis has been associated with heart failure with preserved ejection fraction. So one size may not fit all. Both of them are etiologically heterogeneous and phenotypically heterogeneous. But if you look at the causes, reduced ejection fraction, the causes are ischemic, genetic, viral electrical, where with preserved it is hypertension, diabetes, uh, cardiomyopathies, and amyloidosis. And both of them, this is therapeutically homogeneous, and here we find that there is a differential effect as far as treatment is concerned. So now we know we can treat mid-range heart failure till 40%. So earlier, we know that ejection fraction cutoffs are arbitrary and imprecise. And the data from 3 trials have shown that we can treat patients with 40% and above. So have we, in the past, wasted our time in not treating these patients? Now, after the momentous DAPA heart failure trial in patients with reduced ejection fraction, we now have the Emperor Preserve trial going on with Emperor 10 MD and the Deliver study with DAPA, both in patients with preserved ejection fraction. And there are other trials like the Vitality trial with Verisiquet, the Parallax trial, again looking at ARNIs, and the Spirit trial to reassess the use of spironolactone. Now, if you look at what is the final message for the current management of heart failure with preserved ejection fraction. Number one, it is a diagnosis of exclusion. So always consider alternative diagnosis. Symptomatic treatment with diuretics. Treat hypertension and other comorbidities. Perhaps sinus rhythm or rate control in atrial fibrillation will help. The ischemia should be treated, and we are still looking at the efficacy of spironolactone. What are the potential targets for future? Gene therapy, modulating gene expression in vivo for therapeutic purposes, basically to attenuate mitochondrial dysfunction, modulation of oxidative stress, whether coenzyme Q10 will help or not. I remember Dr. Ejection once gave a talk on coenzyme Q10 long time back. It's again come back into the picture. And the use of microRNAs and incretin-based therapies, multi-targeted therapy to regulate crucial pathways involved in the pathogenesis of heart failure with preserved ejection fraction. So to summarize, it is a real heart failure syndrome. We should not ignore it. We must treat the symptoms with diuretics, treat the risk factors and comorbidities, not only hypertension, diabetes, obesity, but everything, including sedentariness, smoking, etc., whatever is involved in the metabolic syndrome. And in patients with mid-range ejection fraction, we must not forget that we should still use the ER-based MRIs and beta blockers and do some exercise training. We have to address current gaps for the future, and in patients, we have to treat comorbidities and perhaps look for more precision treatment. But finally, we should not forget patient communication. Heart failure with preserved ejection fraction is very difficult for patients to understand because they're going to question you when my echo is normal, how are you telling me I'm having heart failure? So you have to explain to these patients. Thank you, friends, for a wonderful time and giving a patient hearing.
Thank you, Dr. Virmani, for a lovely talk uh, on heart failure with preserved ejection fraction. I think I don't know. So far as my comments goes, probably till today, it is the treatment of mid ejection fraction and controlling all the risk factor is the only option left at present for this preserved ejection fraction heart failure. And it's true, it is very difficult to diagnose and very difficult to explain to the patients also. Now the question, now the house, this is open to the house. Anybody wants to give a comment and question to Dr. Vidmani, he can ask, and definitely he is going to answer all those queries. Dr. Vidmani, otherwise there are two more.
Before anybody asks me a question, I'll request two persons, my mentors, Dr. S.D. Sharan and Dr. S.K. Pal, to please give their comment because they are my mentors. Dr. S.D. Sharan, please, sir, you first.
Anil, it was as good as it has always been. When you are speaking, we just listen. I'm sorry I joined a little late for this topic to make any comment on the topic, but yeah, whatever I heard, it was fantastic from you. Thank you so much.
Thank you, sir. Dr. Pal, please.
Good evening, Dr. Sharon.
Please unmute yourself, Dr. Pal. You're muted.
No, you're still mute.
You are muted.
Dr. Pal.
Yeah.
Yeah.
No.
Still your SPSG.
We can't hear you. Volume, we can't hear you.
Still mic is not functioning properly.
Yeah. He's muted again, I think.
Yeah.
There is something wrong with the mic.
Yeah, yeah. He's muted again. He's trying to speak and he's not.
Okay, so can we move ahead, sir? Because this was a very well explained, I mean, very up to date talk, as always. Dr. Virmani sir is.
True.
So, can I request Dr.
Yes, I would like to add a comment.
Yeah.
Oh,
Okay, please.
please.
Yeah, sir. One thing I would like to add in this, that a heart failure with preservation fraction is mostly most of the time it is not being diagnosed, and patients many times being treated for COPD. One thing for the cardiologist, it is very important to assess the diastolic function of the heart during echocardiography. Most of the time, what we do, we just do the pulse wave Doppler on the mitral valve and give our opinion about diastolic dysfunction. But other features of diastolic dysfunction must also be evaluated properly to give a proper diagnosis whether there is a diastolic heart failure, or that is a heart failure with preserved atrial fraction is there or not. Second thing, that many times if that is not possible even, then we can do a cath study to assess the LVEDP in these patients, where raised LVEDP will definitely help in telling that patients have a heart failure with preserved ejection fraction. And definitely we should not keep our patients away from doing a coronary angiography, because this is one of the very common cause of the diastolic heart failure in those patients who don't have a heart attack and having a normal ejection fraction. But when you do an angiography, we will get a multi-vessel disease many times, or single vessel disease, or double vessel disease. So these things I think have to be kept in mind in assessing the diastolic heart failure. Just doing BNP is not many times helpful, because I see that many patients with having the heart failure preserved ejection fraction have a BNP of not more than 300, 400, and at that time it becomes very difficult to say whether the patient has a heart failure with preserved ejection fraction or not. But when you give diuretics in this patient, they definitely uh, get a very benefited with that medicines. And another medicine which is particular, I will add that will help in this patient is the calcium channel blockers. Definitely calcium channel blockers will help in heart failure with preserved ejection fraction patients. Definitely ARBs and beta blockers are not very helpful as in the heart failure with reduced ejection fraction. Thank you.
Okay. Dr. Satish, go ahead with further.
Dr. Varun,
Sir, can I request Dr. Pratyay to take over, because Dr. Paul's mic is probably not working.
Is it not working? Can you hear me?
Yeah.
So I must say, Dr. Virmani, this is a very confusing topic. And whenever there is a confusing topic, it has to be clear. And the person who clears this is Anil Virmani. So a confused topic has been clearly explained by Dr. Anil Virmani, as usual from this. So I must congratulate Dr. Virmani. You have made it very clear. But there are so many technical things which has to be taken into account. So those things will be always confused to me, like persons who does not know all those things. So anyway, this is a good topic, and you have made it clear.
Yeah.
I think one of the biggest limitations in diagnosis is getting a good echo report. We do not have that high standard of echo reports in our state. So I hope somebody improves on that. Absolutely.
I want to comment on the subject.
We are
Because if you are considering only ejection fraction,
correct.
then you may miss, because always the patients say the heart is okay. But if you consider the strain imaging, then there are three types of strain. Especially the longitudinal strain, that deteriorates very earlier in this case. So, but there is of course, there is an increase in the radial strain. So sometimes it is mismatched that, okay, you see, if you see the heart, it's very good contracting because the radial function is very good and the radial strain is increasing. On the other hand, the longitudinal strain is decreasing. So if you give this longitudinal strain value, then you can pick up those cases early, and this confusion of the diagnosis of the picking up this cases of a preserved reaction fraction will be in a better approach.
So another thing that I have to say is that usually the reports are given by E by A ratio, but more and more newer machines are coming, and you can do TDI in most of them. So we should also look for E by E prime rather than, and that should be the regular, I mean, feature of any good eco report. So
Anybody who's doing strain imaging in Jharkhand? Anybody who's doing strain imaging in Jharkhand?
yes,
Yeah,
sir, we are doing.
I am doing strain imaging, and E by E prime is not sufficient. You have to go for the speckle tracking imaging, and it gives the value of the longitudinal strain. That is very, very important to picking up these cases.
Yeah, so we can
You
do
know one word.
Yeah.
That is, you know, the systolic and diastolic dysfunction. It is said that systolic is the male and diastolic is the female, woman. To understand the diastolic function, to understand the woman is very, very difficult. If you go to the cardiac cycle, there's a 5 component of diastolic and only 3 component of the systole. To understand the 5 function of the diastole is very, very difficult, and basically is a diastolic dysfunction. Just like in a female, it's difficult to understand all the components.
Well said.
Still you are fighting.
Yeah.
So we'll go for the next topic.
Yeah, please.
It's
Go for it.
and it will be chaired by Dr. S.K. Pal sir and Dr. Pratyek Guha sir.
So the topic is recurrent stroke in a young doctor. So the beauty of this topic is that recurrent stroke, and that to a young patient and who is a doctor. So this will be covered by none but Dr. Deepak Gupta. I don't think Dr. Deepak Gupta needs any introduction. Only what I feel to say that the relation of Dr. Deepak Gupta with me. He was my intern, my PG student, and then he went for the DM, and then he came back and started practice in the Patna. And it is, I can say that it is me who has asked him to come to Ranchi, and he has started his interventional cardiology in Ranchi. So, Deepak, please, you start your talk.
Yeah, I'm just going to it.
Yeah.
My screen is visible.
Yeah. Make it
So,
full.
yeah.
Can you make it full screen?
Screen.
Great.
Okay.
Yeah.
So I'm going to present a case of a young doctor which had a recurrent stroke, a diagnostic and therapeutic dilemma. The patient is a doctor, he is a pediatrician, he is a husband of my classmate. One of my classmates is sitting here, delegates, Dr. Satish, he knows everything. And I am going to present this very interesting case and very, the important case. A 50-year doctor friend presented with the CBA while swimming in the club. Few years back, you have heard that one of the colleague, Dr. Urologist Dr. Senapati, had a similar type of stroke while doing the gym. And it is a very common presentation while doing some exercise, while doing some Valsalva, to get a stroke, and particularly the young patient. So this gentleman had a stroke during the swimming in the club. There is a strong family history of the stroke in young and that patient. He was a diabetic, but well controlled with HbA1c 6.5. He was a non-hypertensive. CT done there. He is reside in Varanasi. So CT done there, and it shows the anterior